Okay, so we'll start our conversation today with some. And in reality, this term epilepsy is a general term for sort of any sort of transient neurological event from usually hyperexcitable or increased. We got people still showing up here. Nervous system activity, nervous or electrical discharge. So basically, we'd sort of define this as transient, in other words, short term, increased electrical so the neurons are discharging electrical action potentials, in other words, too, um, in some sort of a random, unpredictable way. And basically, what that means is depending on which neurons are involved, we're going to present with a variety of signs and symptoms. So we could see abnormal muscle function. So that might present as twitches or spasms, um, and they can be fairly severe in that respect. We could see abnormal sensation. Again, remember your cerebral cortex. Think about the areas of the cerebral cortex that would be responsible for sensations versus motor. We could see if the hypothalamus and brainstem regions were involved, we might see some abnormal autonomic presentation. And again, brainstem related, we could see some abnormal effects on consciousness. So again, it's going to be based on the location for this abnormal electrical activity. So the signs and symptoms are going to be variable. The duration and time between episodes can also be variable. It's often singular. A lot of people will experience a seizure, or could experience a seizure once in their life and never again. But basically, it's going to be called a seizure disorder or epilepsy uh, if it becomes recurrent or chronic in presentation. So when I say that one episode is not uncommon, it might be explained by hypoglycemia or some sort of stress episode, that sort of thing. And that wouldn't be diagnostic of a seizure disorder or putting a label on something like that. Uh, let's say only becomes So what are we looking at? What is the cause or etiology that we want to be aware of with respect to these kinds of presentations? So first thing to mention, as I indicated with having a one-off, is that it could happen to anyone. But more commonly is going to be associated with any kind of a cerebral injury. So last week or last session, we talked a little bit about spinal shock. This would be a cerebral shock kind of presentation. Tumors that apply pressure to a group of neurons may cause some hyperexcitability. Ischemia from blood clots. Infections. Alcohol withdrawal. Toxins, including our amino acid toxins that we've talked about, creating a cytotoxicity on groups of neurons. We can have metabolic pathologies, like I mentioned, low blood glucose. That would be more specifically nutritional. So that's that might create an electrolyte imbalance or a water imbalance. We mentioned a decrease in glucose. If I put square brackets in there, I'm specifically referring to blood glucose. That's just my abbreviation as far as that goes. Hypoxia, acidosis. Neurons are particularly sensitive to their environment. So if the pH starts to drop, they're going to get excited about that. Medications. And we could be talking about medications that are causing an adverse reaction or medications that have been overdosed. And sometimes these presentations are going to be of unknown origin. So we would be talking in that case about an idiopathic. One of the things that's sort of diagnostic to epileptic type seizures is that they're often triggered by some sort of stimulus. So there's a bit of predictability in that respect. Often triggered by what becomes a known stimulus. So in other words, it starts to become predictable. And it might be something like flashing lights. So you've seen signs in theaters that say strobe lighting in effect or something along those lines. That's to give somebody that might be triggered a warning that maybe they shouldn't be in that particular theater, but that's where that warning comes from. Thumping music is a known trigger in a percentage of people. Some sort of stress like a fever or fatigue, and those kinds of stimuli. Those are examples of triggers for some people. with these that are prone to these types of seizure presentations. So what exactly is going on with these presentations? What do we know? So basically, the first thing to recognize is that there's going to be a change in the neuron membrane potential. So they become hyperexcitable. So remember what we talked about, or what hopefully you've reviewed. If we talk about a synapse, and this is the axon for the presynaptic neuron, and this is the membrane of the postsynaptic neuron. So we're just going to draw in our double lipid bilayer there, and it's got some channels and receptors for neurotransmitters. So the neurotransmitters are going to be released from the axon of the presynaptic neuron. The action potential travels down the axon, signals these neurotransmitters to be released, and they will match with their specific receptors. And if they are excitable neurotransmitters, they're going to open up channels for a positively charged ion like sodium. And when sodium rushes inside the cell, the previously negatively charged environment inside the cell is going to become positive. That's the cell becoming excited. In other words, if we reach a threshold, we're going to generate an action potential that will travel down the entire membrane of this neuron to the next neuron in the sequence, depending on where we are in the nervous system. Remember those three boxes. Ultimately, that pathway is going to end on an effector. And if you're having a little bit of trouble following this description that I've just explained, then it means you need to do a bit of review. All right, so what we're talking about is the electrical chemical transmission out of synapse between two neurons. So our white axon here is our presynaptic neuron, and our green cell membrane is our postsynaptic neuron. And if we generate enough of a positive change inside the cell, we reach a threshold, generate a new action potential, and that will travel down the axon of our postsynaptic neuron to the next neuron in the pathway. Everybody following me okay with that?
Yep. Yes.
Yep.
Okay. So basically what we're saying then is that in epilepsy or seizure disorders, the neuron membrane potential becomes hyper. So it gets excited. So it's going to be more prone to firing, more prone to generating action potentials for one of these reasons that we've described, because of an injury, because of an infection, or whatever. So it's important for us to recognize that if it's an excitatory neurotransmitter, it's going to depolarize the next neuron. And we talked about, let me just, so remember we talked about glutamate as being a excitatory neurotransmitter. So if the glutamate quantities are not removed effectively, then this cell is going to become hyperexcitable. If it's released in excessive amounts, it's going to become excitable. So if we have membrane pathologies or or, like what we've talked about already. Okay, somebody's put on those closed captioning, that stuff. You've heard me say this so many times. It's worse than helpful. It's worse than neutral. It's just going to confuse you. So if glutamate is excitable, then it's going to be like the example we've shown here, where it's going to depolarize the next neuron and make the nervous system an excitable or hyperexcitable state. So that was an excitatory neurotransmitter. But understand too that we have inhibitory neurotransmitters. So an example is the GABA neurotransmitter, which is inhibitory in nature. So it would, for example, one way that it can be inhibitory is that when it binds to receptors on the postsynaptic neuron, it actually opens up channels for the chloride ion. And when the chloride ion enters the cell, it makes the cell more negative. So that's going to inhibit excitability. So we have excitatory neurotransmitters that promote action potentials and inhibitory ones that would block the likelihood of an action potential because they're going to make the inside of that cell more negative rather than more positive. So basically, you get the formation of abnormal neuron pathways, and that gives us and we refer to that where that is occurring as an epileptogenic focus. This is where the seizure will originate from. So keep in mind that when this action potential forms in the second neuron, the neuron that we depicted here in the color green, it's going to transmit its action potential. It's an all or nothing response. So it'll transmit its action potential all the way down the length of that neuron through its axon to another neuron. So that's going to create a spreading of this action potential signal. So this location, this epileptogenic focus is where this seizure begins, but it's going to spread. And it's basically described as an autonomous So it's an autonomous emission of electrical activity. That's the way to sort of describe what initiates a seizure in the central nervous system. So autonomous means it's on its own. It's independent of a nervous system signal. So the mystery is, why this infection or tumor or nutritional deficiency has caused this to happen. But this is what we know is going to be behind the initiation of this kind of a seizure presentation. We do know that oxidative stress And by now we should recognize that oxidative stress refers to the accumulation of free radicals uh, within the central nervous system is a cause and can result in this abnormal electrical activity. Nearby neurons and neurons that are synapsed with the affected neurons are going to become involved. They get recruited. So that recruitment is what results in the spreading of the electrical activity that ultimately is going to present with one of those symptoms that we described: muscle sensation, autonomic abnormalities. So once enough neurons are recruited, the presentation is going to become observable. So that word is probably not very easy to read. So basically, once we have enough of those neurons that are recruited, the presentation is going to be observable. So that's what we're referring to there. And again, we've said this, but we'll reinforce it. That presentation we're talking about, in other words, the signs and symptoms, are going to be variable. And that variability depends on the location, and degree of recruitment. So how many neurons are actually becoming hyperexcited. So again, that terminology that we talked about when we described focal involvement. So focal onset is going to be the pinpoint or the actual small specific location. And if it doesn't recruit additional neurons, it's going to be a lot easier to identify. But because of the spreading, we may have a presentation that's much more generalized. And then we have another category where, because of the involvement of neurons in more remote locations, we may have an unknown type of onset. So these are types of onset here. So these describe types of seizures. So if we take a look at the generalized form, this is telling us that large portions, for all intents and purposes, the entire brain is involved. So you can appreciate the signs and symptoms are going to be pretty varied. And often pretty severe. And if the thalamus and or brainstem are also involved, then we can have loss of consciousness. Remember, the brainstem is the location for the reticular activating system. The reticular activating system, or the RAS, is essentially responsible for levels of consciousness, levels of awareness. And if we've got hyperexcitability in this area, there's a good likelihood that either during the seizure process or certainly in recovery, there can be some loss of consciousness. And we can try to determine severity based on whether the symptoms are motor or non-motor or combinations of those. So when we look at motor, presentations, we talk about motor presentations by what is observable in muscle activity in someone experiencing that seizure. So what's a fairly common presentation is described as being a tonic clonic presentation. In tonic clonic presentations, there's stiffening, in other words, contractions of groups of muscles. And the clonic part refers to the repetitive jerking type movements. And usually involves large muscle groups. So muscles associated with the upper limb and the lower limb. So that this is the classic presentation that you've maybe seen depicted in movies and television shows where someone's having a seizure and they're sort of writhing and they've collapsed to the ground and they're moving all over the place. But the clonic terminology, let's go to another screen here. So clonic, if we're going to define clonic is really referring to that repetitive jerky movements. And they can be either uni or bilateral. Most often, well, I shouldn't say most often, but oftentimes they will be presented as bilateral. When we talk about the tonic, so tonic, tone, so that's going to be a more sustained tension or contraction in a muscle or a group of muscles. So we would talk about a sudden tensing, or the word we used before was stiffness. Rigidity is another word that you might be thinking of, maybe lasting anywhere from 10 to 30 seconds with no relaxation during that time frame. So that's tonic. That's a more consistent contraction. Clonic is repetitive. Some other terminology related to these presentations: myoclonic is extremely brief, single or very few muscle contractions in one or very few group of muscles, as opposed to massive or large muscle groups. So this is brief, maybe even single. Some of us have experienced this, when you're just about to fall asleep and you might give yourself you might feel yourself have a little jerk in the upper limbs or the lower limbs just before you fall asleep, or while you're sort of in a doze. Some of you might be doing it right now while we're listening to this lecture. But that's an example of a myoclonic type of presentation. One or more muscles. We can have a presentation that's got the myoclonic and then add in tonic clonic presentation. So a little bit of everything. Short jerks, where there's a progression to stiffness and then to shaking. So it has all of the descriptions that we've described in the previous three. So that's presents with 1, 2, and 3. If we say 1, 2, 3, another descriptor is myoclonic. So you know there's going to be some twitching. Atonic and absence of tone. So basically you would have the jerking or the twitching followed by some loss of muscle contraction, some flaccidity. Twitch. Epileptic spasms are sometimes described as infantile, so that gives you a clue as to when you would expect you're going to most likely see these infantile spasms, because they occur most frequently in infants from 4 to 8 months of age. There'd be a little, and that may again be somewhat similar to our myoclonic type of twitch, where it occurs most typically as they awake, and it's and most of the time, this is not related to electrical activity abnormality. It's probably more related in, especially in the case of infantile spasms, more related to development and maturation of the nervous system. Now we can also have, these are all descriptions for motor presentations. You can have non-motor, remember we mentioned, depending on the neurons that are involved, we may have some sensory pathology. So we can have what's described as being typical, or if it's not typical, it's going to be described as atypical. And then you can have involvements where there's both motor and non-motor presentations. So there's some myoclonic presentations introduced. If it's a non-motor seizure, they're more common in children. They're usually brief, and they are going to present something like staring. So their presentation might involve staring, or there may be, and typically they're going to be, so they may be in the middle of a conversation or in the middle of a sentence, and they just stop. So these are sometimes described as absence type seizures. And basically what's happening is there's a quick onset and a quick stop, so that it presents maybe as just an interruption in their speech pattern, and they're completely unaware of quick onset and cessation, and they're typically unaware that it's happened. So in older terminology, this was called an absence seizure, because basically nothing was happening during that time. So that's a more typical type of presentation in what we call a non-motor seizure. And again, more common in children than it is in adults. And an atypical non-motor. We've got the absence type presentation, but accompanied with myoclonic jerks and what are sometimes called automatisms. So that might be lip smacking. It might include some eye flutter, that sort of presentation. So there's a little bit of a motor component to it, but not in terms of the huge presentations we would see if it was purely a motor type of presentation. So they're not going to fall to the ground with these automatisms. They're much more subtle in that respect. So our concern with the motor seizures is that they tend to be much more dramatic. They're sudden and maybe result in loss of consciousness with muscle rigidity. That double M is abbreviation that I use for muscle, just to save writing it out every time. Oftentimes the contractions involve the extensors. So you may see that their lower limbs and spinal musculature promote extension with some adduction in the upper limbs. Again, these are just sort of classic presentations. They're not necessarily the way that all of these motor seizures will present. Lots of concern with tongue biting to the point where the teeth clamp down on the tongue and cause bleeding, even sometimes biting a segment of the tongue right off. There may be a high-pitched cry associated with, then that has a lot to do with air leaving the trachea through contracted muscles, creating that pitch. The concern is that respirations can seize. In other words, respiratory muscles are also in a spasm, so that we may be failing to introduce new oxygen to the system during this time. And there can be bowel or bladder incontinence. So the tonic presentation may result in contractions that can last 10 to 15, maybe as long as 30 seconds at a time, followed by clonic activity. And the clonic activity will follow, and it sort of gives the appearance of rhythmic muscle contractions. They tend to be violent. They can last for longer periods of time, those clonic presentations. So tonic, let's say sort of 10 to 30 seconds, followed by clonic, 1 to several minutes. And it may present with some, you might see the eyes roll. The facial muscles contract to create a grimace. They may foam at the mouth, so there's some increased salivation. And then they take a deep breath when they're coming out of this increased activity. So the deep breath often indicates at least a break in the tonic-clonic presentation. Then there's a phase after the seizure that's described as being the post-ictal phase. This is the phase of recovery. So they're going to regain their consciousness, become aware of their surroundings. And they may drift into kind of a dozy, coma-like state. So they'll initially be kind of a bit confused, like, what just happened? Why am I on the ground? What are you guys doing all around me? That sort of thing. So they're disoriented. They're confused, may not be able to answer questions in terms of who they are, where they are at the moment. Sleepy. And no real memory of the seizure. So again, this is classic presentation. There's lots of variability. But this is kind of the way that these things they'll onset suddenly, right? Like we said, so that we've got a sudden onset and a slower post-ictal phase, right? That's coming out of it, disoriented, confused, with no memory of the actual presentation. Now, what are we concerned about? One thing that we need to be aware of in patients that go through this kind of thing is a condition that's referred to as status epilepticus. So this is a life-threatening situation, life-threatening. And this is a situation where the seizure continues with no obvious recovery. So especially if they're in that tonic-clonic phase with no recovery, then there's a real distinct possibility of, so we'll say because it's a continuous seizure. So our concern with a continuous seizure is that there's going to be ischemia causing irreversible central nervous system damage. So it's death from hypoxia. This hypoxia can lead to cardiac dysrhythmias, lactic acidosis, and there's a real emergency requirement or need to establish the airway and try to stop those seizures. So what we're basically saying is going to happen is that the death can come, death from hypoxia, cardiac dysrhythmia, and you will recall that any dysrhythmia that affects stroke volume, that affects the ability of the heart to pump a volume of blood out of the left chamber in particular, left ventricle, is what we're concerned about with a dysrhythmia. So that's the concern really, is that the sequence of contractions through the heart walls prevent an effective cardiac output. But the lactic Acidosis plays havoc with metabolic functions all over the body, especially the nervous system. So those are the things that will progress or develop with respect to that hypoxia. So most important is to establish the airway and then manage the contractions. So in the interest of treatment, during a seizure, it's maintaining or establishing the airway. So in an institutional setting, there's equipment for all of this. In a recreational setting or a location where we may not be equipped with all that sort of thing, then it can be difficult to establish an airway. I've been in a situation on multiple occasions where someone has had a seizure, and the goal of that seizure from an emergency point of view is to get your patient into a safe location while they're in the midst of these often very violent contractions. You want to protect their head. You want to try to maintain an airway. One of the concerns is they can actually swallow their tongue. Their tongue can be pushed to the back and block the airway. So again, if you have the proper equipment and can do it safely in a first aid sort of situation, you have to get that airway open. And the one thing you're not going to do is put your hands in somebody's mouth to try to fish out that tongue, because the force of their ability to contract muscles associated with the jaw would probably cut your fingers off. So you have to remember that in a first aid scenario, you have to protect yourself, or you're not going to be of much use to helping the situation out if you become part of the problem. So maintaining or establishing an airway when safe and prudent to do so, that's really, really important. And then protection from injury. And then it becomes important, particularly if you're in a situation where you're an observer, or not necessarily operating as a nurse, but more as a first aid individual. It becomes important to observe and be able to report anything that you can remember and note on the time of onset, rapid, slow, how long it lasted is going to be important information. Any precipitating factors, in other words, triggers. What was the stimulus or trigger? Was there any sort of a prodrome? I'll explain that in a minute. So these prodrome or aura is a little bit of a warning. A patient will tell you that they have a sense of an impending seizure. It might be a headache. It could be a single myoclonic jerk. Could be a mood swing or change, a visual or auditory, olfactory or gustatory sense. So some people will say the classic sort of presentation is they might ask you, for example, do you smell burning toast? And then boom, they're into a seizure. So that olfactory sense of burning toast was an example of a prodrome or an aura, a little bit of a warning sign of an impending seizure. So that's referring to a sense of impending seizure. So technically, when we talk about a prodrome, that's the period before a seizure, and the aura is actually the beginning of a seizure. So the aura would be that sense of smell, burning toast, boom, into a seizure, where that sort of general awareness or that sense of an impending seizure is more of the prodrome. But in each case, that it's really a progression into the seizure. So we look at the precipitating factors. Then the other considerations with being able to describe the nature of these seizures is to also observe so this is a continuation from the previous page. Also observe the sequence of the seizure. So did it start as tonic and develop into a clonic or myoclonic presentation? Was there any loss of consciousness? And in the post-ictal phase, we're looking at the duration and presentation. So how long did it take before they became aware of their surroundings? How long did it take before they, became more or less conscious of the environment that they're in, whether or not they have any memory of the seizure? Like we've said already, that typically they won't, but all of that information is going to help localize the focus of that seizure. So it's going to help with further investigations as to where to look for this kind of a seizure. So in some cases, our solution is going to be reached by eliminating stimuli. So in other words, in the investigative phase of trying to determine where this epileptic focus is coming from, we may have to eliminate certain suspected stimuli, whether it's metabolic or toxic or infectious. But the objective of the treatment is to control the seizure activity. And we've got, so the treatment goal is to control or manage seizure activity. So it would be nice to be able to determine and remove triggers where possible. And anti-seizure medications are available. And these anti-seizure medications are basically medications that are designed to reduce the excitability of the neurons. So these are going to be medications that are designed to, for example, attempt to remove excitable neurotransmitters or to minimize the production of those excitable neurotransmitters. Basically, people are put on anti-seizure medications. The doses are adjusted until the seizures can be minimized and the frequency and intensity of those seizures are reduced and are going to be with a goal of ultimately being able to come off of those medications, assuming the basic measurement for that, the basic criteria for coming off the medications is no seizure activity for a time period of about 2 years. And then gradual reduction of the medication dosage, again, with the observation that there's no additional seizure activity happening And in some cases, they can come right off those medications. Some cases of childhood presentations seem to be resolved with age. So there's that awareness too, that there's quite a significant percentage of people, not everyone, obviously, and not the majority of people with seizure presentations, but you can essentially get a resolution seemingly associated with age of the nervous system, and maybe some form of adaptability that occurs that results in the reduction and absence of those seizures. So here we've got a little diagram here that can show us a little bit of a summary of what we've been talking about. Let me get a color that we can all see. So here we have our focal location. So this would be the location of the abnormal excitability in a segment of the cerebral cortex. And it may present as very simple if it stays local. If it recruits additional surrounding neurons, it's going to become much more complex and become a more, what we would be describing as a generalized seizure. So it's going to be recruit other neurons from other parts of the cerebral hemispheres, and that's going to create both sensory and motor abnormalities, which would be dependent on which parts of the cerebral hemisphere were involved. So again, reviewing the segments of the cerebral hemisphere will help you to predict where some of that presentation would come from. We've got the, this is just a little depiction of the intricacies of synapsing within the central nervous system. So you've got a single neuron here that may become hyperexcitable, but it connects to many other neurons and results in that recruitment presentation that we talked about. So it may start as focal and stay focal, in which case it's going to be pretty simple in terms of presentation and predictable, and also be probably a little easier to address in terms of treatment. There are scenarios where they will surgically go in and affect that area of hyperexcitability by removing or blocking some of that nerve transmission there. It's fairly extreme to do that, but there has been some success in treating seizure presentations by surgically interfering with that hyperexcitability in that location. That's going to be easier to do if it remains focal, localized. So let's move on to dementia. The first thing to recognize is that term dementia is not a specific diagnosis, but a description of several nervous system pathologies associated with cognition. In other words, the patient's ability to make decisions and understand their environment and so on. It's what is common with all of them is they tend to be progressive, and the result is a deterioration of memory and cognition. So dementia is not specific, but describes a group of conditions that can be described as progressive in nature, so it's going to get worse, progressive deterioration of memory and cognition. You're going to see changes in behavior, personality, judgment, and distraction. These patients are often going to become very anxious, especially in the early goings, in the early presentations, anxious, suspicious. They often become very aware that family members may be talking about them. They're hypersensitive to that sort of thing. So it's quite a progressive change, and it's very, very fascinating to observe. So basically, what is the cause? What are we talking about when we talk about so the nervous system is going to degenerate, and we get nervous system degeneration and non-neuro those are the general categories for dementia. So basically, when we talk about neurodegeneration, we're talking about observable changes in the nervous system without any indication of another factor being involved. Whereas in non-neurodegeneration, there's nervous system degeneration, but it's because of another underlying factor. And the most common factor is vascular. Um, a reduced blood flow supplying the nervous tissue, resulting in that degeneration. So when we look at neurodegenerative, this is the one the most common cause or the most common descriptor for this type of dementia is Alzheimer's. So we often interchange dementia and Alzheimer's, but in reality, we have to recognize that this is a specific form of neurodegenerative disease. Okay, and the number one non-neurodegenerative, which is number two overall, is vascular. So the same people that are at risk for stroke and atherosclerosis and so on, those other sorts of vascular diseases that you've spent some time talking about, are going to be at risk of this form of dementia. But other mechanisms that can come into play here. So these number ones and number twos are the most common forms of dementia. Okay, whereas Alzheimer's is probably represents somewhere between 60 to 80% of all dementia. And vascular would be the next most common. And then under the neurodegenerative category, there's a form of dementia that's associated with Parkinson's that is going to be distinct from Alzheimer's. There's what's called multiple system atrophy. There's chronic traumatic encephalopathy, CTE, chronic traumatic encephalopathy. This is the type of dementia that, say, someone who's been a boxer all their lives or been in some sort of other contact type sport with multiple head injuries over time. We know that they are at risk for dementia, and in that case, it would be called chronic traumatic encephalopathy. This is why we're much more concerned about concussions now. We recognize that repetitive concussions can lead to CTE. I want to just talk about a couple of other examples here. So when we talk about neurodegenerative, So number one is Alzheimer's, otherwise abbreviated as AD, Alzheimer's. So that's going to be our 60 to 80% of all forms of dementia. So, and then we have a form, we're going to talk a little bit about Parkinson's later today. So Parkinson's dementia is another example. I mentioned multiple systems atrophy. So that's a widespread, that's pretty rare, but I want to emphasize chronic traumatic encephalopathy. So that's repeated head trauma over a lifetime. Football players are at risk of this. Boxers are at risk of this. Soccer players are at risk for this. Anybody who's had repeated head trauma over time. So concussions put you at risk. A one-off, not so much, but any kind of repetition is going to put you at risk for CTE. And so it becomes a real issue as far as that goes. Other chronic conditions like Lou Gehrig's disease, otherwise known as amyotrophic lateral sclerosis, is a progressive condition that often results in some dementia at later stages. There's a form of dementia that's caused by an infection, prion disease. Prions are a type of abnormal protein. So they're not an actual virus, but they are a protein that causes an inflammatory response in the central nervous system. This was described as mad cow disease when it happens in cows. In humans, it was recognized by a couple of researchers, Jacob and Kreutzfeldt. So this is a type, so the issue is that this prion can be transmitted from a cow that's been butchered and sold for meat, and you eat the meat. So the infected cow becomes a mode of transmission to humans. So one of the things that we're very concerned about with mass production of meat, especially from cows, but from other animals as well, is the concern for the transmission of disease that might be present in that particular cow. So if the place where butchering is going on isn't vigilant with respect to the animals that they're butchering and disease, there's a possibility of transmission to humans, and it's happened, and it's ultimately fatal. So this is another form of dementia. When we talked about the neuro, all we're saying is that the origin of the problem didn't happen in the nervous system. So we said that the next most common is what's referred to as vascular dementia. So the source is different. The source is because of an altered or reduced blood flow to the central nervous system. But other examples would be from hypothyroidism. Again, in most so-called advanced countries with advanced medical support and abilities, this is not a very likely or common cause, but these are metabolic conditions that can result in dementia. Cushing syndrome, remember, elevated levels of ACTH resulting in elevated levels of cortisol. Infections, other than the prions that target the nervous system specifically. Mental pathologies, HIV, B12 deficiency. So these are I'm just listing some deficiencies or some challenges that ultimately can involve the central nervous system. B12 deficiency. And so on. So those are just other ways that dementia can develop. Lyme disease is a known one too. I don't know how many people are aware of a musician, very talented musician who just passed away shortly, not so long ago, Chris Christopherson. Very, very, very talented writer and pretty effective performer of his music too. But an old timer. You guys probably wouldn't really necessarily know who he is, but he had been diagnosed with dementia. They actually said he had Alzheimer's, and several years into the diagnosis, they discovered that it wasn't Alzheimer's, that it was in fact Lyme disease that was affecting the degenerative state of his central nervous system. And when he got the Lyme disease treated, many of his symptoms were reversible, luckily enough. But this all happened fairly late in his life, and he's since passed away. So because Alzheimer's is the predominant form, we're going to talk a little bit about the etiology associated with this form of dementia. So we mentioned that it's the #1 overall cause for dementia, and it's very significant in the population over 85 years of age. It's estimated that about 30% of those who reach the age of 85 will have some degree of Alzheimer's, and up to the age of about 65, about 10% have this form of dementia. And we know there's two main factors that we understand are underlying the neurodegenerative mechanism for Alzheimer's. One is an accumulation of what are called beta amyloid plaques. These are extracellular accumulation. So these are collections of amyloid proteins, essentially, that are going to accumulate and cluster between neurons and in the spaces of the central nervous system, and probably have been in existence for years prior to a diagnosis, prior to any signs or symptoms. So we'll just say over years. The accumulations take years to develop. The second observable factor associated with Alzheimer's disease are what are called neurofibrillary tangles, NFTs. These are formed from a protein called tau. So tau is a protein that's normally found associated with neurons, but are going to and they normally support the internal structure of a neuron, but they start to accumulate. So they're described as a neural thread. They're like if we had the cell body of a neuron, the tau would be these fine, thin-like structures within the neuron cell body that are going to promote nervous system function. They help with the shape of the neuron cell body and the transmission and formation of neurotransmitters and so on. So they're a normal protein involved with normal functions, but with inflammation or lipid pathologies and with aging, the tau protein changes. So it's altered from aging, infections, abnormal lipid metabolism. So we know abnormal lipid metabolism is an underlying factor in a lot of conditions, and we now know that it's so. Someone, example, who has diabetes, they're more at risk for Alzheimer's, because with diabetes we know that there's an abnormal lipid metabolism as part of the underlying factors there. So the tau protein is altered, so the tau becomes what's sometimes described as misfolded. So a protein is a three-dimensional structure that has a very distinct formation or structure that results in a particular function. And if you change the structure, by definition, you've changed the function. So basically what's going to happen is the tau becomes misfolded, and it's going to block synaptic transmission. So I've got a picture to show you of those. Let's see what my better picture is. We'll go to that one in a minute, not that one. Let's look at this one. What's this one? Okay. So when we look at this picture here on the left side of your screen here, we've got a healthy, normal, so-called normal brain. So we got good, healthy tissues, and this segment is trying to show you a nice, healthy neuron. You can see that's nice and clear here. In this picture, we see that there is the introduction of the beta amyloid plaques, are the beigey colors that they're showing here, and the tau, the neurofibrillatory tangles, are designed to show you that they've developed first in the cell bodies and then are extended into the synaptic endings, both of dendrites and of axons, so that they're going to interfere with nerve transmission. The other thing that we notice in a Alzheimer's brain is that the ventricles become enlarged, which is really a function of the nervous tissue being atrophied, being reduced, and reduction in cells associated with the hippocampus. The hippocampus is a really integral part of memory and cognition. So it's a center of neurons involved with both memory and cognition. So when that is atrophied, we know those functions are going to be interfered with. And this picture that I started to show you gives you a little more of a anatomically accurate kind of picture here, but we've got the same concept to be aware of here. Shrinkage of the hippocampus, enlarged ventricles. That's really a reflection of atrophy. In this case, we've got the picture on the right is showing you the overall atrophy and reduced size of the cortex compared to a nice healthy one on this side. And here's our tau is being represented in the cell bodies as increased clusters of proteins and the amyloid plaque is extracellular. So tau begins as intracellular and can be actually released through axon and dendritic endings to also clutter the extracellular space, but that's in a more advanced state. So the two sort of primary indicators of Alzheimer's disease is the accumulation of these amyloid plaques and the accumulation of these neurofibrillary tangles, these tau, misfolded tau proteins. So those are the two identifiable features. Now, when you read a little bit about Alzheimer's disease and read a little bit about what we understand, is it's been very difficult to determine whether these accumulations of tau and amyloid plaques are the cause of Alzheimer's disease or the result of Alzheimer's disease, because in both cases, the development or the observation of these accumulations occur only after a diagnosis is being made. So there's no real way or complete understanding yet as to whether these are causes or results of the degeneration that's observed in the central nervous system as a result of Alzheimer's disease. But what we do know is that once they're present, they interfere with the transmission of signaling between neurons, particularly those that are associated with memory and cognition. As a result, those functions are going to progressively deteriorate. So we're saying that, whoops, let's go to a color we can see. 1 and 2 promote diffuse neuron damage and atrophy. Can see almost 20% loss, or let's in those patients with Alzheimer's disease may be able to see as much as a 20% loss in cerebral mass. So it's pretty significant as far as that goes. And what we're also going to see as a result of this accumulation of amyloid plaques and tau, abnormal tau, is that we're going to also see some neurotransmitter pathology. And they come in three main mechanisms. So we're going to end up with nerve cell communication pathology, nerve cell metabolism, pathology. So remember what we're saying, neurotransmitters, they signal next neurons in a pathway within the nervous system. So when we talk about metabolism, without those signals, these cells are not going to get their normal signaling for growth and development and that sort of thing. And then we also are going to have an abnormal ability to repair. So these are the ways that abnormal neurotransmitter function can affect nerve cell survival. and behavior. So, for example, what we see as an observable factor in Alzheimer's disease is that there is low amounts of ACH, acetylcholine. So when we have low levels of acetylcholine, it's going to affect many areas in the central nervous system, as well as the medulla oblongata, well, we'll say, and the cerebral hemisphere, cerebrum. And the imbalance of one neurotransmitter often leads to or can cause imbalances in other ones. So basically what we see is any role that the ACH would play is going to have a primary effect on the medulla oblongata and the cerebral hemispheres in particular, but we also get abnormal levels or abnormal balancing of other examples: serotonin, dopamine. We'll be talking about dopamine a little bit later on today as well. And that one we've talked so much about already, glutamate. So what we suspect is that the increased amyloid plaque accumulations in the extracellular spaces are going to affect the ability of these types of neurotransmitters to cross the synapse effectively to signal their subsequent neurons in whatever pathway we happen to be looking at. So who's at risk? The primary risk factors. Oh, just before we go to risk factors, one thing I want you to realize when we're talking about dementia, particularly we're talking about Alzheimer's in this case, is that what we recognize is we observe these accumulations in both the intracellular and the extracellular spaces. And we observe these imbalances in neurotransmitters. So it should be becoming pretty clear that the dementia that causes Alzheimer's is multifactorial. There are many factors that come into play. And anytime there are many factors that come into play, treatment becomes complicated. I read a book that sort of described Alzheimer's, and we've talked about another disease process earlier this semester that falls into this category, cancer, that's multifactorial. But the visual that this author talked about with respect to Alzheimer's disease is he sort of used an analogy of a roof of a house that has 57 holes in it. And you can plug 2 or 3 of those holes, or 4 or 5 or 6 or 7, or even 10 or 15 of those holes. But the fact is, there's still a bunch of holes left over. And so the roof is still leaking and it's still causing damage inside the house. And that's kind of the analogy for any pathology that's multifactorial. You can address a factor, and much of the research in the last decade or so, and probably a little longer than that, has been directed towards these accumulations of tau and amyloid plaques, but not resulting in the cure or the reversal of the symptoms associated with Alzheimer's. So we know that there are many more holes that need to be patched. And you can use that analogy for a lot of complicated pathologies, cancer being one of them. We talked about the genetic factors and the carcinogenic factors that come from the environment. You can talk about type 1 diabetes as a multifactorial pathology. At one time, we thought it was all endocrine. Now we recognize that there's an autoimmune factor. But again, multiple multiple etiologies contribute to the presentation. So until we can address all of these possibilities, we're not going to come to a very obvious or effective ability to reduce progression, or in fact get a reversal in this case of Alzheimer's. So who's at risk? Who's at risk? Obviously, the longer you live, the more at risk you're going to be. So when we talk about age, we talk about older, right? So remember, if you're asked a question in your not so distant future about listing risk factors for, let's say, for dementia, and you just list age without specifically or specifying that you're talking about an older age as a single word for an answer for a risk factor is not an answer. It's an incomplete answer. So specifically, we say that those who are at risk are people in the older age group. Remember, we said that by the time you reach the age of 65, about 10% of the population is identified as having some degree of Alzheimer's disease. And by the time you get into the 85-year-old age group, it's much closer to 30, maybe even a little closer to 40% of the population, again, has some level or degree of dementia, specifically Alzheimer's in that case. So we have to recognize too that a little bit of dementia as we age is expected. But the more advanced forms that are caused by either Alzheimer's or vascular forms of dementia are much more progressive and much more significant. So we're not talking about, walking into a room and forgetting why you went into that room. We're not talking about sort of having trouble getting the name of somebody that you've met before off the tip of your tongue. Those are not describing dementia. It's easy, the more you learn about any kind of pathology, to suspect you might be presenting with some of those symptoms, but those are not describing dementia, right? This progression that has some physical presentations that support this loss of cognition and memory is what we're talking about when we talk about dementia particularly. Those that have a family history are at higher risk. And again, we're talking about specifically if it's a first degree relative. So that's a mom or a dad or a brother or sister. But even if there's even a slightly higher risk if we see dementia that follows several generations, that's another indicator that family history is playing a role. There are some lifestyle factors that will increase the chances of developing dementia. Especially repeated head trauma. We mentioned diabetes, mellitus, people who are subjected to chronic depression, those with sedentary lifestyles. You know what's going to come next. Smokers. Those two often go hand in hand. Poor dietary habits, which may contribute, for example, to that lipid pathology that we talked about. So we know that processed foods, highly processed foods, tend to be high in sugar, saturated fats, and other factors that can contribute to Alzheimer's onset. So again, these are risk factors. That's not the same as causes. So the presentation has been studied extensively, and we recognize that particularly with Alzheimer's, there are three stages, three pretty distinct stages: early, mid, which would be described as moderate, and late or severe. Early would be mild. So in early stages, the patient can still function. Independently, so they can still live in their own home or live with their spouse or family members. And they can still function relatively independently. They may have trouble with names or getting the right word out. This is very early on. Remember, I said that's not necessarily dementia, but if we're watching or observing the progression, they may have some challenge with recall, like names, or getting the right word out. That kind of thing might be an indicator. And again, oftentimes these are observations that are made historically. In other words, as the condition progresses, you might recognize that, oh, geez, I remember now, a few months ago, grandma had trouble remembering my name when I went to visit. My mom has quite advanced dementia now. And I remember we were on a cruise. We went on an Alaskan cruise with a whole family. And this is a number of years ago, long before she was diagnosed. And she had a terrible time finding her room on the ship. I don't know if you've ever been on a cruise ship, but there's multiple floors or decks, and all of them look the same. They're all just repeated rooms. Behind the room they might be a little different because they either have a sliding door observation, or they have a porthole observation, or they're a suite, or they're a single room, or whatever the case might be. But in the hallway, they all look very identical. And so she had a terrible time finding a room, and it was sort of a joke at the time. And now you look back retrospectively and you realize that was an indication of some loss of cognition. She had trouble recognizing what floor she was on and which room she came from. So that's an early indicator. In group settings, they may have some difficulty with communication. So it gets noisy, and I mean noisy in their brain, literally gets noisy, and there's difficulty differentiating between voices, and maybe differentiating when someone's addressing a comment or a statement towards them. They don't pick it up because all of the noise of the environment is interfering with that ability to recognize a directed statement. So restaurants or crowded environments like a stadium, you go to a large event or that kind of thing. Maybe even at a big dinner, like at a Thanksgiving dinner where there's 14, 15 people around a table. There's more difficulty differentiating between the general noise and a specific voice that might be directing something towards you. They may complain about misplacing items on a regular basis, or losing items on a regular basis. As it advances, they'll start putting things in bizarre spots, like the car keys end up in the refrigerator. that kind of thing. But that would be more in our moderate phase. But it starts with misplacing items, not remembering where you left those set of keys, for example. Planning and organizing become very difficult. So I remember having a conversation with my dad regarding my mom, not to dwell on my situation, but just because it's an example of how the presentation can be. Where a conversation I had with my dad at one point was, if you're planning something that involves us or involves coming up to see us, make sure you let me know about it because your mom keeps forgetting to tell me about one of these events or plans that we're supposed to be a part of. So that was again an indication that my mom, who was the usual organizer of family events, is having trouble with that kind of skill and responsibility. As the condition progresses and starts to become described as being more of a moderate development, this is often the longest stage. It can last years. But this is where there's going to be a complete forget events altogether, either that have occurred or that were planned to occur in the near future. Changes in mood. Patients often become a little more volatile under certain conditions, a little more anxious. They are aware that their cognition is changing and is not as effective as it once was, but are also going to be in denial that there's any problems. Progressive difficulty with recall. You might get repeated phone calls. So someone who's going through this at this stage would phone you and tell you about something that's gone on, hang up, and might call you right back and repeat the entire story. And not realize that they've already, described all of this and told you about all of this kind of thing. They may start to wear inappropriate clothing, so they get dressed for winter in the summer, or they get dressed for summer in the winter, because there's just no sort of logic to that sort of thing. They begin to wander or are restless. There's a phrase that's used for many of the patients that are in this stage that's called sundowning. And this is a phenomena where the patient gets very agitated in the evening. So maybe they've just had supper, they're sitting down to watch some television or whatever it is they might have done as part of their routine, and they get very agitated. So they get up and they walk and they are short-tempered during this sundowning phase. And it may last anywhere from a couple of minutes to a couple of hours and then settles again. But it's very unique to this moderate phase of Alzheimer's type dementia. There may be some bladder or bowel incontinence. May start to present itself at this time, so patients may have to consider wearing, Depends or adult diapers to deal with that sort of thing. This is where they become very suspicious. That's suspicious, even paranoid. They may even experience some delusions. They get very repetitive and compulsive in their presentation and that sort of thing. So again, all indications that this dementia is progressing. And then we get to the late stages. In the late stages, they lose the ability to converse or communicate with those around them, or respond appropriately to their environment. They're going to require 24-hour help, probably need to be institutionalized, unless you've got family members who are capable and available for that 24-hour care. A pretty significant deterioration in their activities of daily living. They often will sit staring out into space for extended periods of time, lose their ability to feed themselves, lose their ability to take care of themselves from a hygiene perspective, need to wear diapers on a regular basis because they're just going to be incontinent. They are inactive. Which makes them prone to infections. And the inactivity also is going to promote more degeneration. So it becomes a vicious cycle as far as that goes. When we look at the prognosis, the really unfortunate thing at this stage of research and care is that the prognosis is not very good. But it is really, really important to rule out other reversible causes. So like that example I gave you earlier, Chris Christopherson was a very famous example of someone who had been diagnosed with Alzheimer's dementia, who in fact had an infection that promoted the symptoms, the presentation of dementia, when in fact it was an infection. And when the infection was addressed, a lot of the signs and symptoms were reversed. His cognition improved dramatically. So it was an example of a reversible sort of situation. So when we talk about ruling out other reversible causes, we're talking about the possibility of endocrine causes like hypothyroidism or our Cushing's syndrome, or infections like Lyme disease or HIV, possibility of a tumor applying pressure to parts of the brain that mimic dementia, those sorts of things. In the event that the diagnosis is accurate in early, the treatment is designed to try to delay the progression. So the goal is to delay progression. So we have some medications out there that have some limited ability to delay progression. Some of the treatment plans are addressing neurotransmitter imbalances. So for example, there's one of the treatments is to administer what are called acetylcholinesterase antagonists. Now that's a mouthful. But if you look at that name, so it's acetylcholinesterase. That's an enzyme that breaks down acetylcholine. So acetylcholine is typically an excitatory neurotransmitter in the nervous system that's going to promote some of the pathways we mentioned in the cerebral cortex and also the medulla oblongata. And the enzyme is designed to degrade acetylcholine under normal circumstances so that it doesn't become hyper-excitable. But in patients with Alzheimer's that have reduced available acetylcholine, this acetylcholinesterase needs to be inhibited. So this is that category of medications that inhibits the enzyme activity are called antagonists to the enzyme. So acetylcholinesterase antagonists are a medication category for early onset, and it's designed to try to prevent the progression of mild to moderate Alzheimer's. So it prevents, or we should say maybe limits, the breakdown of ACH in the cortex. And there are some other examples that follow that principle. In the early diagnosis, the goal is try to delay progression. If it was a vascular dementia, then the treatment is going to be a little bit different. In vascular dementia, the treatment is going to focus to decrease blood pressure, to address, let's see, what do we want to say? To decrease blood pressure, regulate blood glucose levels. That's it. Regulate lipid metabolism. So what we can do, let's just make this a little more clear. So we want to regulate both blood glucose levels and lipid metabolism. We want to eliminate so again, you can go back to vascular pathology, such as atherosclerosis and the risk factors associated with cardiovascular pathologies and stroke, and eliminate those factors when we talk about the treatment for vascular dementia. And in many of those cases, when those things are addressed, a lot of the progression is going to be halted in many cases, not probably reversed, but at least halted. And that's the key part of the treatment plan at this stage of the game. Prognosis is not good. Prognosis of advanced dementia, when we're in that severe stage, pretty much is going to lead to pathologies that result in death, prone to infection, prone to cardiovascular events, and those sorts of things ultimately are going to lead to the end of life of someone with dementia. Okay, let's take a short break.